presentation. طبعا برحب باختي العزيزه الاستاذه الدكتوره اميره ادريس، هي مدرسه واسعه التربيه دايما بتبقى معانا في الأمريكية في النيوناتولوجي وفي كمان حياتنا الخاصه. ربنا يبارك. I have the honor to introduce the first speaker, Natalie Napolitano. I'm going to give more to me about her. She is a research clinical specialist in the respiratory therapy department, Children's Hospital of Philadelphia, where she runs a bench lab and applies clinical research important to the science of respiratory care. She currently serves as the Neonatal and Pediatric Chair on the AARC Board of Directors, as well as a member of the International and Government Affairs Committee to the National Asthma Education and Prevention Program. She is also the current chairman of the Board of Directors for the Allergy and Asthma Network. In addition to her work here in the United States, not here, in addition to her work in the United States, we hope her work in Egypt will be the same. She serves on the pediatric, I don't know what one is. Anyhow, he has a lot of things to be done, so we are happy to have you with us. Thank you. So, she will give us the first talk. Please welcome her. The most difficult in any science is to tell anybody the basic things. Although people think that basic is something easy, but I'm sure that as I'm a neonatologist, that basics of mechanical ventilation will be the hardest one, and you are lucky to hear it from Natalie.
Thank you very much. Good morning, everyone. Thank you for having me. I'm very honored to be here with you this morning and over the next couple of days. I actually had a very wonderful, uneventful trip over here and spent yesterday at the Egyptian Museum, which was fascinating. It was so wonderful to learn everything about your history and see all the objects that you have there. This is actually a picture of my hospital in Philadelphia, and I love this picture because our hospital actually changes color at night. The way they have the lights on the glass. And it was about a year before I even saw it at night because I'm always there during the day. So when I saw this picture, I'm like, wow, it actually really looks like that at night. So we are going to talk, starting at the basics of mechanical ventilation. And as a professor said, remembering your basics with anything and making sure that you're sticking to those really helps you help your patients as you're moving forward and you get into your advanced modes. These are all the different companies that I do research with. It's something that we, just so that you're aware, for any conflicts of interest. Draeger, who is one of the makers of the ventilators that you all have here, as well as CVS Health is one of our pharmacies in the United States that we're working on a program with. So just to get us started, these are an overview of what we're going to be discussing. The basics of our settings, what they mean, what they're doing for us, the different modes. For just our basic modes, Brian will be talking about all of our advanced modes, so I didn't stick to any of those. And what our advantages and disadvantages are simply of those from the basics level. What are our goals, making sure we're all staying with our basic goals of using ventilation in general, always remembering to go back to that. We get very caught up in our advanced modes and what we want to do that we forget about our basics a lot. And then troubleshooting. When certain things are happening, what can you do still within these basic modes to help your patient? So these are all the different settings that we'll talk about a little more in detail. The triggering of the mode or the sensitivity and how the breath gets delivered to the patient. The respiratory rate or tidal volumes. The peep or the positive end expiratory pressure. The inspiratory time, which I feel is almost one of our important settings that people forget about a lot, and the FiO2 or the oxygen that we're delivering. So talking about our trigger, this is something that all of our machines have. that you can change and you can set, and knowing exactly how this works helps you determine how it makes it easier for the baby to breathe. If it's not set right, nothing else that you change is going to make it easier for the baby to breathe, and it's one of the first things to go to. There are 3 different ways that the ventilator can be triggered from basic modes. The first is time. And this is when you're controlling all of the ventilation. There's a set time frame with your inspiratory time and your respiratory rate that a breath is delivered. And it's the full mechanical breath that's delivered to the baby. As we get into some of our spontaneous modes, there are 2 different ways. One is by pressure, and this is when the demand valve on the ventilator will open up when it reaches a certain amount of negative pressure. So you're taking a deep breath in, or you're starting to take that breath in, and as soon as it sees a certain amount of pressure that is requested, then it gives a breath. And this oftentimes, depending on your mode, whether they get a full controlled ventilator breath or a spontaneous breath with a little bit less pressure. The second and final way is by flow. In a lot of our modes, particularly in the neonatal modes, there's a continuous flow of gas that goes through the circuits that's called bias flow. And the ventilator constantly monitors what comes out for bias flow and what comes back to the ventilator through the circuit with bias flow. So once they pull a certain amount of flow from that bias flow, the ventilator recognizes that there's less flow coming back, and that will deliver a breath. It's a little bit slower method, but it seems slower. But the process is so quick, and how quickly our ventilators measure doesn't really delay the breath as much as you would think it is. But this, again, would be for ventilators, full breath, or one of the spontaneous breaths with less support. And setting tidal volume, this is the amount of air that's delivered with each breath. It's generally milliliters or liters if you're an adult, or it's bigger. And this is generally the initial tidal volume that we set for the patients. We go by their size or their disease process. Some diseases we give bigger than less. It's generally measured, and we'll set it according to milliliters per kilogram in the U.S. And this is usually a targeted setting that you set if you're in a volume mode of ventilation, but if you're in a pressure mode, you'll get a reading of what the exhale tidal volume is. And even though you set the pressure, and that's one of the main settings, it's what we order, it's what we're thinking of, we always need to be monitoring what the exhale tidal volume is, because that tells us if we're getting enough ventilation to the patient. This is also one of our very critical settings and critical things to monitor as to whether or not we're providing lung injury. So we used to think that too much pressure going into lungs is what was causing injury. With a lot of the animal studies that they have done now, it is really volume and how much volume that's going into lungs that we know causes injury. So we always make sure that we're watching how much is being delivered, that we're not providing too much volume for a small amount of pressure. Next is the inspiratory pressure, and as I said, to me, this is one of the most important settings, making sure that it's set appropriately. And this is how much time you spend during inspiration and taking that breath in. And it is generally how much you set it in centimeters of water pressure, and then you'll get your volume that's delivered, and making sure that you're setting that reading. If it's a volume mode, then you want to monitor that as much as you're monitoring your volume in the pressure modes. In the past, this was predominantly how we always ventilated infants and babies. And in many places in the world and in the United States, pressure modes is still how we, most of the time, ventilate our babies. And we'll be talking a little bit more in the next coming days about the use of volume modes, and volume limiting and volume guarantee, and how that might be beneficial, knowing that volume, not pressure, is what causes the injury in the lungs. However, when you have airway leaks, if your endotracheal tube is a little bit too small, or when you're getting very high pressures because of your lung compliance, sometimes this is easier and safer to use than volume ventilation. So we'll also be talking about those challenges in trying to determine with each mode. A respiratory rate, and this is the number of breaths that the ventilator will deliver. The mandatory breaths, as we oftentimes call them, and they're the full supported breaths. However, the infant or anyone can always breathe above that, whether they get a full supported breath or a little bit less support depends on what settings we have for the spontaneous rates. And this is the optimal number that we originally set really depends on the patient and their age and how much of your tidal volume. So we really want to target a minute ventilation, which is your tidal volume and your respiratory rate together. So if your tidal volume is on the small side, you need a higher of a respiratory rate. If your tidal volume is larger, then you need a little bit smaller of a respiratory rate. Our PEEP, or positive end expiratory pressure, this is the amount of pressure that we don't let the patient exhale at the end. We hold that pressure in, and that helps to really compensate for the endotracheal tube being in place and all of the circuitry to the ventilator to make sure that the alveoli don't collapse. Oftentimes when we take away the entire upper airway and all the natural processes that this part does for you, you need a little bit of pressure just because we're taking all of that away. Our initial setting, again, depends on patient size and their disease. As we talk about BPD or chronic lung disease, we'll see the larger peak levels, at least that we use at our hospital, that isn't done universally. Generally for newborns, depending if you're preterm or if you're term, 3 to 5, honestly, though, for me, I never really go below 5 because PEEP, even though it's extra pressure on exhalation, doesn't really cause as much damage. In my mind, and through some of the studies, although the jury's still out on the evidence there. This will affect your mean airway pressure and your oxygenation. If your alveoli stay open, the gas can get across into the bloodstream. Our inspiratory time, this is how long the inspiration lasts on our mandatory breaths. And this is always measured in seconds. Oftentimes, people think that they set that inspiratory time, and for every breath that the patient gets, they're going to get that inspiratory time. But on just about every ventilator, there's spontaneous breaths the patients get to pick their own inspiratory time, and a lot of the dynamics of that breath. And we'll get into that with a couple of the modes shortly. This will also affect your mean airway pressure, your tidal volume, if you're in a pressure mode. And it also can assist with your oxygenation, as well as your ventilation, depending on if it's greatly enhancing your tidal volume or if it's affecting your mean airway pressure. If it's too long or if it's too short, it can negatively affect your ventilation. It can actually cause injury into the lungs, and we'll see that this afternoon in a couple talks with our chronic lung disease patients. And just, this is one of the things I touch on with every single one of our fellows that comes in, because they're not sure how to set inspiratory time and how to use all of our graphics. So this is our pressure time waveform that we see on the ventilators, and at the peak you can see where there's active exhalation trying to occur with the patient, right where the arrow is there. This should be flat. If you start to see that peak, that means the patient wants to exhale before you're letting them. You're making them continue to inhale. So seeing that peak means backing off and shortening the inspiratory time a little bit, so the top of that is flat. And that's one of the things that can really help us guide to make sure our inspiratory times aren't too long or too short by guiding what they're wanting to do. The FiO2, it's necessary. We need to use oxygen in most scenarios, but we also know how harmful it has become. So depending on the age of your patient, whether they're preterm or term, we change our oxygen goals and making sure that those are clearly identified for everyone. And we always use the lowest level of oxygen possible, and this is measured in a percent, to meet our goals. And making sure that we're not getting any adverse consequences from that, as we can get absorption atelectasis, injury to the lungs, as well as injury to the eyes that can cause us a lot of problems in the future for the baby and anyone trying to manage their ventilation as they get chronic lung disease. But this is one of those factors that we don't realize a lot of times is really damaging. And for us in the United States, the nurses are really good at making sure they're weaning this down and only giving the baby what they need when they need it, because they're the ones standing at the bedside most of the time. So looking at some of the different modes, we'll discuss assist control, and you can use versus volume or pressure targeting or setting in assist control mode. SIMV, or synchronized intermittent mandatory ventilation, where the patient can breathe spontaneously a little more freely. And this can be controlled by volume or pressure. Some of our adaptive controls where you're setting one thing but you're really delivering it a different way, and we'll discuss that. And then pressure support ventilation. One thing I'm not going to talk about is CPAP mode. We don't use that a lot in babies. We're making them breathe through a straw and do all of that work. At least in the United States, we don't use it all that often. I'm not sure if you all use CPAP here. It's used a lot in adults, but I haven't touched on that except through a ventilator. So for assist control modes, this is full support on the ventilator. Every single breath, even if the patient initiates the breath, is a full supported breath. Fully controlled inspiratory time, fully controlled how much pressure, how much volume, depending on how you set. If it's set as assist control volume, then you're setting the volume and you need to be monitoring that pressure to make sure the pressure doesn't get to be too high. If you're set as pressure, then we want to be monitoring the exhale tidal volume to make sure that the tidal volumes aren't too high or too low. If your compliance starts to change in a pressure mode, your tidal volume is going to drop and start to go too low. Whoever is setting the ventilator has complete control over all of the dynamics of the breath, pretty much, so you know they're getting exactly this pressure or exactly this volume for this time and how often they're getting them. Any additional breaths that the patient starts to breathe, they'll get that full breath. Some advantages of this mode is you're getting that guarantee. You know how much ventilation is happening even with their spontaneous breaths. So you know they're getting full support. The disadvantages is that if they start to breathe more, they're getting a full supported breath. So you can start to have overventilation. If they start to breathe really fast or get desynchronous with the ventilator, you can get hyperinflation and intrinsic peep that is very hard to measure in neonatal modes on ventilators. And then you can get respiratory alkalosis. So if we're not monitoring that closely, some negative side effects can occur. And then also you get increased work of breathing as the desynchrony increases. So it's kind of like a vicious cycle that occurs as soon as they start breathing on their own and getting these full breaths. They want to exhale and you're trying to make them inhale. So they start to hyperventilate, they start to breathe faster, they start to almost get really uncomfortable. Sometimes you can see them starting to cry as they're crying. They're triggering a breath every time with the full breath. So oftentimes with babies, when they're more awake, this isn't the best mode for them. For our synchronized modes, you can also deliver a set tidal volume or a set pressure according to your preference. But as for whatever their minimum rate is, you're still controlling all the dynamics of that breath. But every time the patient breathes a spontaneous breath, they can start to control the dynamics a little bit more. They set the inspiratory time, and since it's synchronized with the ventilator, if the baby takes a breath, and it was the right time frame for the ventilator to give a breath, it won't give one, so that it's not giving a double breath on top of the spontaneous breath. And that causes a lot of the desynchrony and a lot of the uncomfortableness in breathing on a ventilator. You can also set the level of pressure support. All the spontaneous breaths are pressure controlled instead of volume controlled, and you can set that level of pressure support to be a little bit less than their full ventilation, so they won't get this full breath every single time that they try to initiate one, but they'll get some support to make it more comfortable to breathe. And the fact that they can have control over the dynamics of their breath makes their work of breathing a little bit less with this mode. So the advantages is it improves synchrony between the ventilator and the patient. With the timing, the baby can breathe when they want to. They won't get a double breath from the ventilator at those time frames, and they can control the dynamics of their breath. We've seen that you get improvement with ventilation as well as oxygenation because the baby isn't fighting against the ventilator. And you get a lot less of missed or inefficient breaths where you can watch them, they're trying to take a breath, but you're not getting that trigger on the ventilator. And that oftentimes is a consequence of intrinsic peep. And you don't need to use as much sedation for them to try to make them comfortable breathing. Disadvantage is they can continue to breathe as much as they want to without some of the negative consequences, but you can still get hyperventilation and you can still get respiratory alkalosis if you're not watching them. If they start to pant away at 90 breaths a minute, you're still going to have all the negative consequences that we did with the control modes. Adaptive control ventilation is an overall bucket term that we use for our modes where we set a tidal volume, but it's really a pressure-delivered breath. where we're delivering, the ventilator will say, I want a tidal volume of 10, and for each individual breath, it will change the amount of pressure they use to deliver that tidal volume. So as the compliance and resistance changes within the lungs, then the amount of pressure that you need will change to deliver that tidal volume with each breath. Volume targeted ventilation is another way of saying this. Each ventilator company has their own name for the same type of mode. They have it trademarked so nobody else can use it, but they all pretty much do some of the same things. So pressure regulated volume control is one of them. Volume targeted ventilation is another. Volume guarantee is another name for them. Volume targeted ventilation targets the exhaled breath from the prior breath to set the pressure for the next breath going forward. But still, you're setting the volume that you want delivered, and it is a pressure-controlled breath that is being delivered to the patient every single time with each breath. Some of the advantages with this, there's the reduced amount of lung injury because you're setting that targeted tidal volume instead of the targeted pressure, so you know that you're maintaining a consistent tidal volume every time, but you're getting the benefits of the lower amount of pressure each time. So for those who believe that pressure is still the injury, for those who believe that volume still causes the injury, these modes give you the best of both worlds because you're getting to set your pressure, your volume, ensuring that you get consistent ventilation, as well as getting the lowest amount of pressure possible for each breath. The disadvantages of this mode is that it relies on accurate exhale tidal volumes to be measured. So you have to have a airway flow sensor in line with the baby, and it needs to be working correctly. There's a lot of things that causes problems with airway flow sensors, whether it's secretions or humidity, the airway leaks. If your airway leak is too much, then you're not getting an accurate measure of the tidal volume for the flow sensor because it's coming out the mouth. So then these modes won't work very well. Pressure-supported ventilation is when the patient controls their respiratory rate, their inspiratory time, their inspiratory flow, and their tidal volume. We provide just a certain pressure level with each breath, but they have to initiate each and every breath. But they get to control everything else, just like we're breathing right now. This provides a little bit of extra support, but only when the patient initiates it. Advantages of this mode is that you get much better synchrony, much less work of breathing that's involved, a lot better patient comfort. The disadvantages is your patient has to keep breathing. So our babies that have apnea prematurity don't do very well in this mode because there's no backup ventilation. If they don't breathe, they don't get any breaths. And you have this very variable breath pattern oftentimes with their periodic breathing. So this mode works better when they get much older, still under radio of age, but when they're still in that premature time frame, they're getting ventilation. So guidelines for initiating mechanical ventilation from a basics point of view. Unfortunately, there's still no consensus or no standard out there that says you use this tidal volume or this pressure and this rate for premature infants or for term infants or for premature infants that are now post-term. So it really changes according to their disease process and how much lung injury they received and how premature they were. So we always have to go back to our basic goals of mechanical ventilation, making sure that we're carrying all of those out, especially when using any of our advanced modes before we get into their goals. You want to make sure that we're optimizing alveolar ventilation. We're moving enough gas so that we're eliminating CO2 and getting enough oxygen in. We're maintaining a normalized lung volume for them, whatever normal is for that age range, which will change depending on when they were born. We're improving oxygenation to whatever our goals are, depending on their age range. Reducing their work of breathing as much as possible, as well as minimizing any lung injury that we possibly can. We know that having to deliver mechanical ventilation in general causes injury. There's not much that we can do about that. It's going to happen, but we can minimize it as much as possible by ensuring, in theory, that our tidal volumes and our pressures are as low as possible, and they're not working very hard to breathe. You want to set initially your FiO2 moderately, making sure that you're getting enough oxygenation, and then wean it aggressively down. We don't generally start at 100% oxygen when setting our FiO2, and our babies usually somewhere around 60 or 40%, and then weaning down according to their pulse oximeters. Your initial tidal volumes for preterm infants are generally around 4 to 6 mLs per kilo, and then for infants anywhere from 5 to 8 with normal lungs, depending on why they're going to be intubated. So if it's a baby who has a surgical problem that doesn't include their lungs or their heart, generally 8 is okay for the short period of time that they're going to be ventilated. But for our preterm infants and their underdeveloped lungs, we really want to use a little bit lower the tidal volume. The frequency, again, depending on when they're born, if they're premature, it's going to be anywhere from 40 to 60 breaths per minute. In an infant, anywhere from 25 to 40. And always monitoring to make sure their minute ventilation is in range, their CO2s that we're getting back on their blood gases are what we want to be seen, or through transcutaneous oxygen. And that will change according to the range of your tidal volume. Peep levels, always in initial settings, starting at 5, and then making sure you can titrate down or titrate up according to your oxygenation needs, and if there's any airway injury or airway collapse on your chest x-ray. But initially starting off 5 is generally a very good starting point. And then for our inspiratory times, for premature, it's going to be 0.25 or out to 0.4 seconds for each individual breath. And again, really watching our waveforms to make sure if we're starting to see that peak at the end of inspiration where the patient is wanting to actively exhale, shortening that inspiratory time a little bit. And it's one of those settings that oftentimes people kind of set and then forget about it, and they think, well, you're 25 weaker, therefore you're going to need this inspiratory time, and now you're 2 months old and you still have the same inspiratory time. So that is something that can really be changed day by day, week by week, according to what the patient needs at that time, whether they're awake and they're breathing more, if they're sedated, and we really should be monitoring that and changing it a lot more frequently than we generally do. For infants, it will be anywhere from 0.3 to 0.5 seconds. For troubleshooting, some of the most common problems that you'll see is the alarms for high peak pressures, or we'll have airway leaks that will cause low pressures, ventilator synchrony, looking at your patient, looking at the waveforms, seeing how we're not really in sync and not working well together. And oftentimes we see all of these happening when our babies with respiratory distress syndrome or chronic lung disease or BPD. And with both of those disorders, it will change minute by minute according to what their problems are and what their needs are. Some of the things to troubleshoot if you have high peak pressures is if your ET tube is blocked. So making sure first we're suctioning, seeing if there's a problem with the patient, and then looking to see is the endotracheal tube in the right spot. The change of a centimeter on some of these babies, because they're so small, can make the difference between my endotracheal tube is out or it's too far down into the right main stem. So really making sure that the endotracheal tube is positioned where it should be. Sometimes it's positioned exactly where you think it is, but the baby has so much fluid and gained a lot of weight with the fluid in their tissue. And when your face gets bigger, your ET tube may stay in the same spot, taped to the gum, but your face gets bigger, so it moves it out, and you need to move that down. So that's one of the things is we have fluid shifts in and out of the tissues that we really need to be watching where the endotracheal tube is and move it accordingly. Also, with respiratory distress syndrome, making sure we're checking the chest x-rays as their lung compliance changes quite drastically, especially pre and post surfactant delivery. And then, again, to synchrony. If they're starting to double breathe with the ventilator and they're not synchronizing well, then you're going to get high peak pressures if you have 2 breaths on top of each other. Things that you can do, particularly for your respiratory distress and BPD babies, if they're concerned for breath stacking or they're breathing too much with the ventilator, then you're going to get auto peep or that intrinsic peep, and that can be very damaging. So options is to decrease the respiratory rate, give them a little bit more time to breathe in between for their spontaneous breaths, or more time to exhale if that's the problem. Adjusting the flow rate, they might need a quicker flow rate. If they're really breath hungry, then increasing that flow rate so that they can get that quicker breath. Or adjusting their inspiratory time because maybe it's too long or too short for them. They want a bigger breath or it to happen over a longer time frame. Decreasing their tidal volume. If their compliance has changed drastically and you're in a pressure mode, you might be giving them too big of a breath. Sometimes all we can do is increase their sedation if they're really fighting that much until you can figure out to make sure that you're getting the ventilation appropriately on the ventilator, take the patient out of the picture, make sure the mechanics are working right, and then find the right sedation level for them to keep them comfortable. And then when we're also with our EPD or even with respiratory distress, increasing the PEEP. Oftentimes if the airways are collapsing a bit because they're premature, increasing the PEEP to stenting the airways open, making sure that that's adequate and so that you can also exhale. Getting the breaths in, getting the breaths out are just as important. So if you're collapsing and your PEEP isn't good enough, you can't get them in or out. And then you also may need to consider some of the advanced modes, and these are, Brian will start to discuss within the next talk, if you can't fix any of those problems. If the patient is increasingly agitated or having dysynchrony with the ventilator, then options that you can do is, first of all, what we always do is try to give them a little sedation first, just one dose, make sure it's not the ventilator that's the problem, and making sure that the settings are appropriate. And then as the patient wakes up a little bit more, making sure that we're changing things so that they can work together in synchrony. And then obviously, most of the time it's our tidal volume adjustments, flow rates, and inspiratory time that we generally need to change. And when you're changing your tidal volume, remembering to change your respiratory rate as well, to making sure that you have that same minute ventilation target. Because if you have a really good CO2 level in the blood where you want it to be, and you change the tidal volume but don't change the respiratory rate or the patients are breathing spontaneously, then your ventilation will then be too less or go out of whack. Any questions for our basics?
This is you or us?